So now we are moving for our session 12, Pelvic Venous Disease Symphosium. So now I would like to invite on stage our chairperson, Dr. Devendra Dekivaria, Dr. Rashad Vishra, Dr. Sandeep Agarwal. I would request to all our chairperson, would you please come and join with us on stage for our next session, session 12. So ladies and gentlemen, we are absolutely ready for our session 12, Pelvic Venous Disease Symposium. So over to our chairperson. Thank you.
The first speaker of this session is Dr. Shriram Narayan from Singapore, and he will speak on a very burning topic, the pelvic venous disorder, pathophysiology, diagnosis, and the SVP classification.
This is a 1-hour session on a topic that many people might be just getting used to. So we will try and keep this quick, but also try and keep this in some detail. We used to call this condition pelvic congestion syndrome. This was a basket diagnosis that was there for a whole host of symptoms that occurred usually in women's pelvises. But we have now realized that it is essentially a disorder of varicose veins in the pelvis and has been renamed as a pelvic venous disorder with an ICD name, pelvic varices. So I've got a couple of talks in this session, and in the first part, what we will try and do is help you understand the disorder and how it presents, and how you can distinguish it from some gynecological conditions which are common, especially endometriosis, and understand the need for the kind of imaging you need. And I'll introduce a simple algorithm which works for us in Singapore, and then later on we will talk about what to do if you don't have all the equipment and tests needed to manage this. So if you really look at these, the symptoms are so common in women. Chronic pelvic pain, especially getting worse just before a period. They're called menstrual cramps by so many people. There's some amount of backache, some painful periods. Sex can be painful. They bleed heavy, have clots. Bleeding can go on for 7, 8, 9, 10 days. After they've had a couple of children, they are a bit incontinent. There's some urinary frequency. There are funny, vague bowel symptoms which are called IBS. They feel fatigued. They feel a bit dizzy when they get up in the morning. And this thing is constantly passed between the gynecologist, the urologist, the psychologist, the general practitioner, and now the vascular surgeon. And so the problem we have with this condition is that firstly there's a lack of physician knowledge on how this takes place. There's a lack of public perception. Your mothers tell you that if you have some period pain, it's just something you should live with. When you get married and have babies, your pain will get better, so you have prescription babies, and it doesn't get better, it actually gets worse. And then after that, they say after your second baby, it'll get better, and it gets even worse after the second baby, and so on. The problem also with this condition is that although understanding and diagnosing it takes some practice, the interventions are actually extremely simple to do. And so it's low-hanging fruit for somebody who wants to make money is that he can start putting coils and foam and glue wherever you like and get away with it. And anyway, they're suffering from a lot of pain, so it's not much of a problem. And so the basic problem is we were never supposed to stand. We weren't supposed to sit for long hours. We were not supposed to be this ultra slim size 0. That's not what our body was designed for. We weren't designed to have pregnancies at 34 and 35 when we've had our career on track. We were certainly not designed to be sleeping at 2 a.m. and completely disturbing our cortisol rhythm, and that makes your veins floppy. We were not designed for that. But this is the modern human. When you should be sleeping in Calcutta, you stay awake because Wall Street is open. And that has totally upset our circadian rhythms. The other problem, of course, is that we've created this compression where the left renal vein crosses from the left to the right towards the IVC and gets trapped between the superior mesenteric artery and the aorta. If you're on all fours, this falls forward and you feel a lot better. And therefore you get this nutcracker phenomenon where the compression is at the aortomesenteric angle. If you're very slim, then the compression will be much more because normally you have a fat pad that spreads these two arteries apart and the compression is less. Of course, if you put on a lot of weight, then your momentum descends into the pelvis and compresses the iliac vein instead. So if a woman is very thin, she's going to have a nutcracker. If a woman is very fat, she's going to have iliac vein compression. So they just can't win. So find somebody who's somewhere in between. The result, therefore, is that you can also have a posterior compression of the renal vein if you have a retroaortic renal vein, but that is not that common. And so there's transmission of back pressure from the left renal vein into the left ovarian vein. Remember, the left ovarian vein drains into the renal vein. The right ovarian vein drains directly into the IVC. So although, again, unscrupulous interventionalists may consider right-sided ovarian vein embolization as normal, we are presenting at the European Congress that almost always the right side does not need treatment. Treat the left side and the right side will resolve on its own. It is pathologically not usually affected. So a pelvic venous disorder is essentially caused by raised pressure from 2 points, either coming from the left renal vein and ovarian vein or coming from an iliac vein compression and transmitting back into the pelvis through the internal iliac vein. Now, this pelvic venous network is pretty complicated, and that complicated pelvic network also communicates through the pelvic floor with the leg veins. So you have a pelvic floor, you have the uterus above, the vagina below, the bladder above, urethra below, you have the rectum above, anal canal below, and the veins communicate in between. As long as you've got good pelvic tone, there is no leak through the floor, then you decide to have your children, your 3.5 kilo bundle of joy comes out, but on the way out it destroys the pelvic floor. And when it does that, the veins then begin to communicate with the legs as well. We now know that there are 4 at least specific escape points. We've identified a 5th, which is also due for publication, the clitoral point, but you have a perineal point, an inguinal point, an obturator, and a gluteal point, specific points in the pelvic floor where the veins in the pelvis leak into the leg. These can be found on angiography without a problem, and some of you may be familiar with these sort of groin veins that you see. Once you see groin veins like this, the pelvic floor leak has already happened. Then you have something called POTS, paroxysmal orthostatic tachycardia syndrome. When you have these huge reservoirs of venous blood in the pelvis, and then you suddenly get up in the morning or you shift around, there's a shift of this low oxygen blood, and if your autonomic system is a little sensitive to this, you get orthostatic tachycardia. You can get unexplained abdominal pain, heat and cold intolerance, and probably the best management for these is Daflon. We have found that high-dose Daflon reduces the POTS symptoms far more significantly than any beta blocker that used to be used in the past. Learn to differentiate with these two. Chronic pelvic pain due to pelvic congestion syndrome is there across the cycle. Endometriosis, the pain is usually during the cycle, though later on, as the adhesions develop, it also lasts across the cycle. They have presacral varices, so they have low back pain when they sit down. Essentially, they're sitting on varicose veins. Congestive dysmenorrhea, which is pain during menstruation just around the time of the period, that is more typical of endometriosis. Painful intercourse, during intercourse, it could be either. But pain that lasts after intercourse, and we have patients in whom the pain can last for 1 or 2 days after the intercourse, that is typical of pelvic congestion syndrome. And of course, it causes a lot of emotional angst. If your only memory of intimacy is pain that is going to last for 2 days, then you and your husband can live in different rooms very quickly. You have some odd bowel symptoms and POTS and brain fog and things like that. With that came about the SVP classification that was published in May 2021 in the Journal of Vascular Surgery, accepted by 14 societies of radiology, gynecology, and vascular surgery around the world. SVP is a sort of extension of the CEAP classification. S stands for symptoms, V stands for venous reservoirs, and P stands for the pathology. And of course, it is used to describe research. And we have divided the whole of the venous system into 4 zones. So I'll try and show that to you. If this highlight works. Doesn't work. Okay. Zone 1 essentially is from the renal vein to the pelvic floor. So it includes the ovarian vein, It includes the adnexal veins, which are above. Zone 2 are veins which are around the uterus and around the ovary. Zone 3 are veins which are below the pelvic floor, which is in the superficial inguinal pouch, your vulvar varices, paravaginal varices. And zone 4 is essentially the lower limb. So you have these 4 zones, and each of them has specific symptoms related to them. Your venous reservoirs could be either renal hilar, they could be above the pelvic floor, which is the adnexal and ovarian varices. You can have zone 3 varices, which are the extrapelvic veins, and zone 4 are essentially varicose veins. And of course, you have the pathology, which could be reflux, obstruction, or congenital. So this is used to describe, just like in the CEAP classification. This has now been there for about a year and a bit. And this is a typical venogram of a patient down the ovarian vein. You should have forward flow from the ovarian vein going up towards the heart. It should not reflux back into the pelvis in the supine position. And then you can see that arcade form like that, which is essentially varicose veins in the fundus of the uterus. And that's why this patient will have huge hematuria. This is not adenomyosis. We can also use it as a guide to treatment in what is the problem that you're trying to treat, where is the interventional target, and what are the solutions you need. So we have a stepwise approach where we follow a simple PCS score with a key index. You can have menorrhagia, whether they have back pain, and what is the psychological impact. We then developed a PCS score that is now being trialed across North London because it has an extremely high sensitivity. If your score is very low, then you almost certainly don't have a pelvic congestion syndrome. You probably have a gynecological disorder. If your score is high, you almost certainly have a pelvic venous disorder. And this correlates very well with hemodynamics on duplex. It's a simple score. Go on to our website. You can run that online and test your own score if you're a lady. And this tells you what the score means for you too. It's a guide to referral. So basically, this is the primary pathology of a pelvic venous disorder. A nutcracker or a non-thrombotic iliac vein lesion, communication between these systems, and a reflux of this blood through the pelvic floor into the pelvis. And so, in the next part, we will discuss specific assessments and the role of dynamic pelvic floor ultrasound, the role of Daflon and physiotherapy, and what interventions are possible. Thank you.
Thank you, Dr. Sriram. Very interesting presentation. And always pelvic congestion syndrome raises more questions than answers. I guess if open for discussions, it could be hours of discussion. But I'm told no discussion. Yeah. All right.
Our next speaker is Dr. Rahul Jindal, and he will speak on the low-cost ovarian vein embolization in the pelvic vein disease.
So I'm going to talk about the treatment options. So we already know the definition. Sriram has covered it in detail, and this is a very important document which we have seen. And this is a typical picture of the presentation of these patients when they have a reflux into the legs. Medical treatment, NSAIDs, you can only use for short term. You cannot use for long term. Psychotropic drugs has been studied a lot of publications, both gabapentin and amitriptyline. At 1 year, patients were significantly better, but for how long you're going to use the medicines? Hormonal treatments has been used, but long-term uses, of course, is associated with osteoporosis. So both methoxyprogesterone and GnRH agonist has been used, and they have got relief in 40 to 60% of these patients. Now, MPFF has been studied, and there are one very important publication by Gavrilo. He studied pelvic varicose veins versus pelvic and gonadal varices, and he found that if we give that 1 gram per day, pelvic varicose veins has got more pain relief. But the important thing is that if you use it for 14 weeks, the symptoms totally disappears. And even after you stop it at that point, the clinical effect persisted for 6 to 9 months. But this is like a very limited publications on this. So, we don't have a huge experience, that really works or not. Open or laparoscopic surgical treatment, definitely not, because it's too invasive. Sclerotherapy, definitely you can use it in some patients. Either you can use a dilute or a foam sclerosant, and you can use it in the veins in different areas, which are the results of pelvic venous congestion. Pelvic vein embolization is a treatment of choice, and serious complications after this time of treatment are very rare. And the aim of embolization is to occlude the reflux. So what Dr. Shriram has shown you, a very vein reflux from the top, and so where the valve is not there, just like in the legs, we have an SFJ junction incompetence, so you can use the similar technology in a similar concept of closing the varicose veins, just like in legs, in the body, in the tummy. Now, various techniques you can use. Foam sclerotherapy, coil plus foam, balloon guided foam sclerotherapy, coils, glue closure, and there is some publications of using a radio frequency catheter into the ovarian vein from Ukraine. Okay, so not much publications are there, but I'll be a bit skeptical to use heat there, because as you know, the ureter is very close, it crosses the, that part of the body, and I will be slightly reluctant to use a heat energy there. When you can get away with simple things. Our approach is right internal jugular approach, cannulate renal ovarian veins, look for the diameters, reflux and stasis, and once we are inside that, and then you embolize it, and then you can also assess an internal iliac vein with occlusion balloons. Now, how do you cut down the cost? Because see, all these are simple catheters to cannulate, to see the ovarian veins. But the major thing, the cost in Indian setup is the coils. Each coil costs 10,000 rupees. And if the ovarian vein is 15 millimeter, which is quite common when you get these patients symptomatic and in the time when they get treatment, you have to use at least around 10 coils to close that, 8 to 10 coils each side. You may be able to get away with maybe 5. But let's say if you have to use in both sides, you will require approximately 10 coils at least to close the vein. So this is quite a bit. So what you can do, what we have found is you can cut down the cost a little bit. This is reflux in the right ovarian vein. On Valsalva, you can see arising from the IVC. We cannulated it, and you can see a beautiful venogram down there. And, you can see the flow, you can also see the leaking point which is going below the pelvis into the leg. What we have used is, we use a 3% foam along with the contrast, and because that, normally it requires around 4 to 8 ml of foam. You can measure it when you inject the contrast, you know how much volume is required, so that the foam does not get reflux into the main vessels. So then you can see the stasis of the flow here. We have injected around 8 ml of foam with contrast here, and the flow is pretty much reduced. So then you take a 5 French catheter inside with a micro, and then we can put in a small amount of glue. We use a very, very dilute glue. So this glue is 0.5 ml of glue with around 2 ml of lipidol. So the advantage of this is it can go quite deep inside if you want, and also the micro catheter does not get stuck with the glue. And we inject it slowly, and so that we can actually keep very, very big veins. You can close up with this glue, and the glue does not go up with the flow. You can use a balloon occlusions to put in the glue inside that, and so just to make it better. So once we have come into the main areas where the veins are big, and all the tributaries which are draining into the ovarian vein gets closed, then you can put in 1 or 2 coils up there, and a small amount of glue at the top back again. So actually talking the amount of coils which you have to use, you cut that down to maybe 1 or 2 coils if you have to do both sides. So here we have closed it, there is no reflux here. And similarly on the right side, on the left side we put in the glue. Look at the size of the ovarian vein there, and we have put in 2 coils on this side, 1 coil on the other side, and you can get away with 3 coils. So So you can get pretty good results at much less costing. Of course, the complications are coil migrations. The costing of the coils is a problem, and the recurrence of the PCS in around 5 to 6%. If you look into the long-term results published by Mark in phlebology, these were the initial reflux patterns which were shown, and at 6 to 8 years, the reflux pattern in 18 patients out of 28 patients, there is no reflux. So, and if you look into, only 4 patients has right internal iliac vein reflux, and 4 patients has got left-sided internal iliac vein reflux. So the number of reflux really reduces a lot, and it is the effect of the occlusion remains for quite a lot. If you look at all the publications with more than 50 patients, which is published, and most of the people have used coils with a pretty good results of 90+ percentage in these patients. This is one of the latest publication published in 2021 with ovarian vein embolization with glue, and this is done in 18 patients and with a very stable and good results at 6 months. So in conclusion, it's a complex underdiagnosed cause of chronic pelvic pain in female patients. Identifying that this is the cause of the pain is very important, because just you seeing a mildly dilated ovarian vein on an ultrasound, and the patient may have a pain from the endometriosis. So that is very bad for the patients if we treat them. And I feel glue, if you know how to use glue, you can get these patients out in a much less costing. But if the patients can afford, then coils is a very good alternative combined with foam. Thank you. So this is the UIP consensus document if anybody wants to go through it. Yeah.
Thank you, Rahul. Very nice way to cut short the cost. Now we invite the third speaker, and he will be online from Turkey. Dr. Swat Dogansi will speak on the iliac vein stenting for the NIVL in the pelvic vein disease.
Hello, everyone. Do you hear me?
Good evening.
Yeah, I think you hear me, right?
Yes, we can hear you well. Yes.
Okay. And first of all, I'm very sad that I'm not with you there. This year I couldn't join. Rahul knows the reason. But even through online, I'm together with you, and I salute all my Indian colleagues from here. It is always nice to be among you. And I also want to thank Rahul again for including me even online to give a lecture. And I listened Sri Ram's and Rahul's wonderful presentations, and they give very wonderful presentations as always. And now I will try to submit some issues related with deep venous stenting. So now I'm sharing my slides. So it was very nice to hear a clear definition of pelvic venous disorders, and also the role of glue and coil embolizations in also pelvic venous problems. But the other issue is many of those patients can have some problems related with obstruction. Some of them can be non-thrombotic occlusions, but some of them can be post-thrombotic occlusions. As we know that chronic venous obstructions can be in 2 indications like nivels, as we know them, iliac vein compression and renal vein compression. And at the thrombotic side, we have acute and chronic thrombotic occlusions. So for the nivel part, we all know that we have 2 main problems. One of them is the iliac vein compression syndrome. Most of the time we call them May-Turner syndrome. And the other one is the renal vein compression syndrome. Most of the time we call it Nutcracker syndrome. When we look at the literature, this is the first article published by May and Turner. So in that presentations, we know that they didn't define the compression. They were just talking about a spur-like formation in the compressed area, and they are not mentioning about the compression syndrome as their presentation. And the second one, which we know that as the iliac compression syndrome, which is published by Coquette and Thomas. So actually, when we look at the literature, these are the ones who are talking about compression. So maybe it is also possible to call them as the Coquette syndrome as well. But when we come to the diagnostic criteria for May-Turner syndrome, I think we have very big questions mark because we are treating those patients without having clear, let's say, criteria to treat them. What is the main indications? Is there only a more than 50% lumen reduction is a good idea to treat them, or a surface area reduction greater than 0.4? And which diagnostic tool are we using? Duplex, MRV, CT, IVUS, and also when we come to the venogram findings, either collateral venous circulations, contrast stagnations, contralateral cross-filling, balloon testing, and IVUS findings. So when we combine all this together, we can still make some idea, but there is no clear-cut definitions to give them as a scientific background. And also almost the same thing for nutcracker syndrome as well. So Ram mentioned very good things about the nutcracker syndrome. So I don't want to go into detail, but I just want to show you that this syndrome has been defined anatomically in 1937, almost 100 years ago. And we are still talking in 2023, but still we know this syndrome. However, we don't know the clear definition for that. And when we come to the clinical features, the most clinical presentation of nutcracker syndrome includes, of course, pelvic pain, flank pain, hematuria, gonadal varices, reflecting pelvic and renal congestion, and also orthostatic proteinuria. So when we combine all these together, what is the most important clinical presentation and what is the most important diagnostic criteria? We are still having some problem. Is it pain? Is it swelling? Is it venous claudication? Is it pelvic congestion syndrome? We have all those question marks in our minds, but we are still treating our patients without having clear-cut definitions or clear-cut scientific background. When we come to the diagnosis, of course, the diagnosis of compression syndrome is confirmed mainly on imaging results, including duplex, CT, MR, as I explained. But however, these diagnoses can still be challenging to confirm based solely on imaging. Presenting clinical signs, symptoms are there paramount when considering management option. And dynamic duplex should be, I think, one of the most important tool helping us that we should do it in flat and upright positions. When we look at this image of a May-Turner position, we see that in the patient's lying down position right now, it looks like there is some compression, but when we put the patient up, we see that this compression is released. So what we should do? And also this is a nutcracker position. As you see here that it looks like there's compression, but when we put the patient up, the compression relieves. So I think in order to make any decision for a compression syndrome, we should think a lot. And always we should do dynamic duplex scanning, which is very important. And this is an article published by Dr. Kezviten's group about the illusionary angiographic findings of significant iliac vein compressions in healthy volunteers. So these are very young ladies with no complaints, but had an iliac venography to make a decision making. But sorry, at the end, when they found that there are many of the patients showing some iliac vein compressions without symptoms, they say that, of course, diagnosis of the true iliac vein compressions remains a major challenge, but I think the most important thing is we should treat the patient rather than the image, which is very important. And in the deep venous stenting in venous acute deep vein thrombosis, I think from my point of view, following the thrombectomy and lysis procedure, if there is a residual stenosis due to compression, either iliac vein or the external compressions resulting from a tumor and some other issues, we can stent the patients, but IVUS, I think, should be a must in those patients, that we should know that we cleaned everything inside the vein. And in PTS, I think the indications are much more clearer than the other parts. But again, if you ask me, should we stent every patient? My answer is no, because in an asymptomatic patient, giving any therapy is nonsense. And simple edema itself shouldn't be an indication for stenting as well. So patients with claudication, patients with ulcer, patients with lower quality of life scores and higher Wheelhout and VCSS score should be a good candidates for stenting. We know the classifications from Dr. Humanjalai, and especially the group 4 AB and 5. These are the extensive chronic venous obstructions. An inflow assessment is the base for this, but nowadays there is no objective criteria to think about the inflow assessment. We know that we have many things to decide, but we don't have any objective criteria to say that if we have some flow above this is a good inflow. At the moment, this is not possible, but we are working on it. The volume flow measurements, I think, will be a good objective criteria to guide us to treat those patients. At the moment, there is no standard for measurement. Changing from machine to machine, easily affected from patient position, expression, and also the day of time of the day, patient volume status, everything can affect those measurements. But if it's a standard, it can be a good objective parameter. These are one of my studies which is not published, but I just wanted to show you the volume flow comparisons from affected side and healthy side. As you said, that for the index and the healthy side, there are significant differences between them. If we are treating especially one side, the contralateral side can be a good decision-making area to decide if there is a good or some similar amount of flow to decide. And I think volume flow measurements will be in the future guide us. As a conclusion, my friends, when stenting in compression syndrome, patients must be evaluated very strict about the correctness of pathology and the necessity of stenting, and we should avoid unnecessary stenting and size correctly, avoid stent migration. At the moment, nowadays, we know that stent migration is a hot topic. So if we will maybe diagnose an unnecessary patient and give them a small stent and short stent, there is no, I think, option that this stent migrate. So I think if a stent migrate, it's a very big problem for the patient and for us as well. And if we are stenting in PTS, stent patients with severe symptoms, strict assessment of inflow, and we should also respect contraindications like poor inflow, morbid, obese, immobile patients, and patients with problems with anticoagulant usage. Thank you for listening.
Thank you, Dr. Suwat. Excellent presentation, as always. And it's my pleasure to present Dr. Sriram for his second presentation. Now it's part 2, management algorithm with and without pelvic venous duplex and IVUS.
Thank you very much. Suwat raised some very important questions. Firstly, how do we know that the compression is significant? You're right. There is no evidence that the degree of compression, 50, 60, 70%, correlates with symptoms. So we can't use that. We also know that normally 70 to 90% of people will have some degree of compression in the ovarian, in the renal, or in the iliac vein. Does that mean we stent the whole world? So these are two important questions, and therefore what that arises from that is that the symptom and the clinical assessment is the key. You have to find out which is the key index symptom that you're trying to treat. Is it menorrhagia? Is it pain? Is it dyspareunia? Is it flank pain? Is there low back pain? Is it POTS? And each of these has to be approached differently. The score helps to decide as a screen whether overall you might or might not need intervention. But we then developed this algorithm. If you think they have pelvic venous disorder, the first thing to do is run the PCS score. If the score is less than 2 or less, please send them to the gynecologist for a full gynecological assessment. If it is more than that, then we can start thinking of making an assessment. But the underlying rule is this AQUAS acronym that we came up with. You do not intervene in a patient, whatever the diagnosis, unless they meet the AQUAS criteria for us. What is AQUAS? A is agony. The patient must feel the pain. Q is quality of life. How badly is that quality of life affected? Can they not do social events? Can they not go to the school events? Can they not, do they have to sleep for long? Is the brain fog affecting their life? Do they have urinary symptoms, in which case there should be a urological assessment? Have we ruled out other pathology? Pelvic congestion syndrome is just one sign. There could be endometriosis, there could be ovarian cysts. And sexual dysfunction, because sexual dysfunction itself is an important psychological issue. If they are score positive, I will take it from left to right. The first thing to do if you think it's ovarian is to assess the renal function. Patients who have hematuria or proteinuria, you should not be coiling them, because if you stop that coil, it is essentially stopping that pressure transmission into the pelvis. So all the back pressure from the compression will go into the kidney and you could lose the kidney. And if that is abnormal, we will do a MAC3 scan to look for differential renal function. If it looks like the kidney itself is being affected by the compression, then open surgery and not endovascular, which is a gonadal vein transposition, is what we would do. Now, if the score is high, we take them for a transabdominal transvaginal duplex. If that is positive, which I will come to, and they are also AQUAS positive, then we will take them after a pelvic floor assessment and plan intervention. If they're negative for AQUAS, they get pelvic floor physiotherapy and Daflon for 3 to 6 months. Only if you need to intervene, we then move on to a CT or MR to make an assessment. Now, the transabdominal transvaginal duplex, sadly not universally available, is an extremely important tool. We look for the varices, we look for the incompetent veins, we rule out other pathology in this. We can look for involvement of bladder and rectum. It requires the patient to fast for 6 hours, otherwise you will only see the dum biryani floating around in the abdomen. They need to drink 500 ml of water before we scan, do the abdominal part first. They then go and pass urine and come back for the vaginal part of the scan. Specific diagnostic criteria. You must see pelvic varices greater than 4 millimeters in size. There has to be a slow flow of less than 3 centimeters per second. Above the pelvic floor, reflux must be spontaneous in the supine position, not Valsalva induced. Below the pelvic floor, it can be spontaneous or Valsalva induced. You must look for large dilated varicose veins crossing the uterine body, because that is the cause of menorrhagia, and if that is present, you're almost certainly going to need a combination of glue and foam. And whether they have adnexal, paraurethral, paravaginal varices, and whether that correlates with their symptoms: urinary frequency, paraurethral; coital and postcoital pain, paravaginal. So you can sort of pinpoint which of these varices will require treatment. On the abdominal part, we are looking for some key findings. A reversed flow in the internal iliac vein, which is flow back in towards the pelvis. You're looking for loss of phasicity in the common iliac waveform. This is important, as Nikos Labropoulos showed. The presence of phasicity may not suggest or rule out obstruction, but the absence of phasicity is diagnostic of a significant obstruction. So there is no way you will stent somebody who's got a phasic common iliac vein. I won't go into the veno-arterial flow index at this time. I'm happy to discuss it later during tea if people want, but it's something we use as a guide. So these are very large volume varices in the pelvis on a transvaginal duplex that you can see. These are bilateral adnexal varices. That's the left adnexa. Adnexa is around the uterus and the uterine body. This is on the right side in this patient. And there you can see the body of the uterus and a large myometrial arcade crossing. This lady had periods that would last 18 to 20 days every month, so that was not pleasant. On an abdominal ultrasound, you have to show spontaneous reflux in the ovarian vein, not Valsalva induced, whether it's the right side or the left side. And of course, you look at other extrinsic causes of compression. The dynamic pelvic floor ultrasound is where we ask them to do the Valsalvas as well as to contract to see how the pelvic floor moves. It allows us to pinpoint where the pelvic floor leak might be. And it's a very important part because pelvic physiotherapy is an important part of the supportive treatment for these patients. It's pointless just coiling and removing the volume of the reservoir. There's a fair amount of publication for this. What used to be called vulvodynia is again pelvic congestion syndrome and is now pelvic venous disorder. The cross-sectional imaging, we first do the urine for blood and proteinuria. You look for hilar varices on the duplex. It's not easy to see, but if you have either that or abnormal urine, we look for a differential scan. If there's either a retroaortic renal vein or if there is some sign that the renal function is being affected, we go for open surgery, not endovascular. Make sure gynecological abnormalities are ruled out, and low back pain could well be orthopedic as well. So these are the principles of intervention in pelvic venous disorders. First, stop the upstream transmission of pressure. If it is an iliac vein compression that is significant, you might need to treat the outflow. It is not significant 50% on an IVUS. It is significant if their pelvis hurts enough to affect their life. Reduce the volume of that venous reservoir, whether you ablate it with foam, which could be balloon controlled, or without balloon control. You have to choose a route for how you're going to get to that reservoir. Are you going to get to it from the ovarian vein or from the internal iliac vein? Or if it is in the vulvar and paravaginal region, you get to it through ultrasound guidance and direct puncture. If you can identify these pelvic leaks from above the pelvic floor to below the pelvic floor, you have to stop the pelvic leak. So glue or foam those points as you identify them on venography, and the leak is bad enough to go into the lower limb. Of course, you might need lower limb venous intervention as well. And you have to manage the perivenous inflammation, MPFF 2 grams a day for 3 to 6 months. In many patients, MPFF alone with pelvic physiotherapy is sufficient. We are just, like I said, going to present the data in Berlin that less than 30% of patients who are significantly symptomatic will need intervention after conservative therapy. So we always give a start with conservative therapy. Now you plan the interventions based on an algorithm. You have various options: ovarian vein, ovarian sclero, iliac stenting, sclerotherapy of the varices, combinations of these, but don't forget the supportive therapy. Those who know me know that I love IVUS and I use IVUS for everything. I even brush my teeth in the morning with an IVUS catheter. But in this scenario, I can tell you that it is not really that essential. Yes, if you're going to stent in an IVL, then you will need it for stenting. But beyond that, it is not really required. So what if you have no TATV duplex, no IVUS in your setup? No problem. All is well. There are ways around it if you don't have these options. Option one is that you do a full clinical examination and you can actually do a simple duplex of the abdomen and pelvis where you can see if there's spontaneous ovarian vein reflux and if you've got pelvic varices. You don't have to look at phasicity and stuff. And then you can combine that with the CT venogram. The problem with the CT venogram, it will show the vein, but it won't show whether it's refluxing. The contrast will fill the whole ovarian vein, and it will fill the myometrial varices as well, so you don't know whether there's reflux. So that's one option if you have a duplex abdomen and pelvis access to that. If you don't have even that, then do your venogram very carefully. Make sure that catheter tip is in the renal and not inside the ovarian vein when you take the picture. Because if there's spontaneous reflux down the ovarian vein with the catheter tip in the renal vein, then it is significant. So if you can do that. So that's your option two if you don't have these things at your disposal. And finally, understand these venogram targets well. That is the pattern, cross-pelvic parallel collaterals in an NIVL. That is the pattern that you will see in a post-thrombotic kind of collaterals. And that is the ovarian reflux. So now you know where your target is to get to the venous reservoir, internal iliac or through the ovarian vein. So my summary is this: symptom assessment is key. Use the score and aquos to decide whether to intervene. Demonstrate the hemodynamic change before going in. Plan supportive therapies for everybody: physiotherapy, psychology, MPFF. And choose your target reservoir based on the symptoms and venogram and, if required, IVUS. But treat the reservoir causing the symptoms, don't treat the picture. Thank you.
Thank you, Dr. Shriram. Now you will show some cases and over which the panel discussion will be done.
I will only show one case to keep the time,
Yes,
and that
yes,
should
yes.
sort
Yeah,
of
sure,
cover,
sure,
and
sure.
we can all discuss it. And I
Yes.
will run through this one case. If I can move to my next presentation, please. There are 3 cases, but you don't need it. One should give us a flavor of
Yes,
what we
yes,
need
yes,
to
yes.
discuss.
Fair enough, fair enough.
Okay. So this is one of my earlier cases in 2018 before COVID. It's a 36-year-old girl, 19th of May 2018 I first saw her. She was referred to me by a urogynecologist. Our pelvic congestion syndrome practice was just beginning. 10-year history, and this is typical of chronic pelvic pain. She's had multiple laparoscopies, suspected endometriosis that was never found. She has 2 children, oldest was 18, so she obviously started having babies early. On the PCS questionnaire, she scored only 3 out of 6. This was the earlier questionnaire before the PCS specific score started. She had pain on sitting and standing, perineal and buttock pain, severe at menses, and the period would last for 8 to 14 days. They were heavy, they were clots, fairly typical. No history of hematuria, no history of renal colic, no blood in the urine. She's had multiple admissions for abdominal pain in the last 10 years. She's typically Chinese. Oops. Can we go back? So she's had multiple admissions. She's very, very slim. She had lower abdominal tenderness even if you move the organs gently. I thought it might be PID, even abdominal and transvaginal. I didn't even test this. Scan planned. Okay, she was admitted suddenly with acute abdominal pain before we managed to do the transvaginal scan, because we do the vaginal scan the week before the period if possible, and that showed nothing. And this is common. In a plain CT, you will often find nothing unless you target the looking for the pelvic varices, but she had nothing seen on a plain CT. We did the scan and we found that she had a dilated 6 plus mm left ovarian vein, a thickened endometrium, and she had varices as well. This was an old pelvic congestion syndrome scan from our side. It has evolved since then. Now I had decisions to make. She has no hematuria, no leg swelling, no varicosities. Is it a renal nutcracker or is it an NIVL? Where is this coming from? Should I do balloon-controlled sclerotherapy to reduce the reservoir, or should I embolize as well, because is the pressure coming from the left ovarian pain? Or should I do both, because she has bleeding as well as pelvic pain? What should be my coil size? I know the ovarian vein is 6 mm, so I'm looking at an 8 to 10 mm coil size. Stent the iliac vein, low BMI. We know that if you do iliac vein stenting, you're going to get chronic pain, chronic back pain from it. Internal iliac vein flow was normal. Assessment was difficult because of the size of her adnexal veins. And how do I approach these varices? Do I come in from the iliac side or come in from the renal side? These are the sort of decisions you have to make. So that's her venogram. I think. Yes, so that's the venogram that you've seen, and so she's got primary ovarian venous reflux, and you can see the large sort of myometrial cascade suggesting that this is the cause of her menorrhagia. I then did an IVUS to run it down, ran it right down into the pelvis itself through the left ovarian vein, and that's the IVUS pullback. But there are some key IVUS findings here. We had adnexal varices, but periureteric varices as well. You can see the aortomesenteric compression there, suggesting that she has a significant nutcracker. Below, at about 7 o'clock position, is the aorta, and about 2 to 3 o'clock position, you can see the superior mesenteric artery. She had no NIVL, so she doesn't really need significant NIVL, so she doesn't really need stenting. And I didn't make the option of measuring the ovarian vein size at this time, which I have started doing since. So if you watch this left one carefully, you will see the balloon for foam-controlled sclerotherapy, and it will go pop. That is me rupturing the left ovarian vein. And you can see the contrast extravasate on that picture further down on the left. And now I learned that the IVUS sizing of that ovarian vein is important on how much you should inflate the balloon, because I have managed to rupture the ovarian vein, which means I can't foam this patient anymore because the foam will disappear into the peritoneal cavity. I don't know where the coils will land, so I was forced to use an amplaxer plug, which you can see. And the problem with using such a large plug is that you can cause ureteric obstruction because it is so close to the ovarian vein. But I had no option. I had to do it. Fortunately, I got away with it, and I learned a lesson. And the lesson is, later on, she recovered well. Her PCS score came back to 0 because we'd stopped the backflow, and she feels like a new woman. This is how scans look. This is when you have an NIVL, so the iliac venogram is normal, and this is another patient where the ovarian venogram shows a large transpelvic collateral. Now I'm happy to discuss the case with the panel, and what would you all think I should do in this sort of scenario?
The session is open for the question and answer. Dr. Shriram, why you punctured this case from the left femoral vein?
I usually go into the saphenofemoral junction. There are people who go down the neck.
Okay.
There are those who puncture the neck.
Okay.
Those who puncture the neck are usually planning to cannulate both the ovarian veins, because the right ovarian vein is a little difficult to cannulate because of the acute angle from the femoral. But when you accept the pathology that the right ovarian vein is rarely involved, and if I need to do it, I'll do it at a later sitting, and I'm predominantly going to concentrate on the left, because that is where most of the pathology is, or I'm going to look at the iliac veins. So to pass an IVUS catheter and to be ready for an iliac vein stenting, I have to go down the femoral route, which is why I usually go down the femoral route, and if in doubt, do a small puncture and do a right femoral venogram as well. And I don't usually puncture the femoral, I puncture the saphenofemoral junction below the pre-terminal valve. Okay. It is easier to compress because it doesn't sit on top of the pubic hair, however much you shave it.
When you have to cannulate the right ovarian vein, you cannulate from the jugular vein?
I try to do it from below first, but the angle is acute. You can cannulate and take a venogram of the right ovarian vein from the femoral. But if you start trying to put coils and foam in it, you really have to go through the neck. That angle is too acute to allow the larger catheters. So you have to go through the neck. So yeah, this is typical. She does not have transpelvic collaterals. You can see that she's probably going to be bleeding a lot because of these large pelvic varices around the uterus. And she's going to need a combination. She will need foam to ablate the uterine varices, otherwise she will keep bleeding. She's going to need something to stop the back pressure from coming down. Now, depending on the cost, you can use glue. We are moving more and more towards just glue and no coils, or just one coil like Rahul put, even though we have access to coils. But too many coils are really not necessary, and they add too much to the cost. So a bit of glue, balloon-controlled foam, and a little more glue above that seems to be sufficient to avoid the cost of coils in most patients. So,
any experience of migration of the foam or glue or the coil into the pulmonary circulation?
That's why you're using balloon control with the Fogarty.
Even after removing the balloon?
No, we haven't seen that. In fact, we do know that the larger the ovarian vein, the more the incidence of coil migration. Yeah. Coils have been removed from the right heart. But foam we know would go, but if you keep the balloon inflated for 5-7 minutes patiently, if you wish, even scrub out, go have a coffee and come back and let the foam act, rather than be in a rush to deflate and take that balloon out, you are safer. But the coil is an implant you leave behind, and we are even more worried if they go on to have a pregnancy, because the ovarian vein can dilate normally to about 2 centimeters during a pregnancy, and you've left a specific sized 12 mm, 14 mm coil there. We don't know what happens to these coils when they get pregnant again. There's some publications saying it's okay, but you're still worried about the coil moving.
Do you give some amount of the low molecular weight heparin just before the procedure, as we give in the radiofrequency ablation? Low molecular weight heparin. Enoxaparin.
Low molecular weight heparin.
Oh yes, everybody. And you go into a vein. We give low molecular weight heparin for varicose veins. We give it for varicose veins. Not just ovarian vein, femoral vein punctures, definitely low molecular weight heparin.
Okay, Shriram, thank you very much. Fantastic talk. And now we move to the next session. Thank you.